Good evening. We'll talk about hip and groin pathology today. There are four major topics that we're going to be covering. So in between, if there's any doubts, just make a note of it, and then we'll discuss that later at the end. Okay. So the first one is iliopsoas tendinopathy, and so we'll talk a little bit about the anatomy and pathophysiology of the iliopsoas muscle. If you look at it, the iliopsoas is a powerful flexor of the hip, right? And it's composed of four muscles. Three major muscles are your iliacus, your psoas major muscle, and your psoas minor muscle. And the psoas major muscle will take its attachment from T12 all the way to L5. So it takes its attachment from the vertebral body and the transverse process. So like you can see here, it takes its attachment from the muscle, from the transverse process and also from the vertebra. And it is a diagnostic more gold standard that way to get a positive test. If there is manual compression test that is positive, right? And so how would you evaluate a patient with this problem? One is you take a thorough history. So you're going to ask the patient about repetitive activities, especially in high flexion. Like say, for example, there is a patient who's sitting down and then he's doing the competitive bicycle. Or if there is a patient who does a lot of running where he's getting up from a squat and running, or a football game, or a ballet dancer. So they have this kind of repetitive activities. And the patient can also complain of pain when when he or she is trying to climb stairs or climb downstairs, trying to get up from a sitting position. Okay. And so the pain can also be a pseudo osteoarthritic type of pain where the pain will radiate down your thigh or the groin. It won't reach all the way to the knee joint.
Every lower limb case starts long before the incision, from hip stability to foot biomechanics. One missed structure can change a patient's mobility forever. Real expertise begins with understanding movement, not memorization, because every joint carries function, balance, and independence. Hip to foot, every level demands precision anatomy, trauma, reconstruction, functional restoration. And the outcome isn't measured on scans. It's measured in every step the patient takes. Master lower limb anatomy beyond textbooks.
With these tests, right? And what will you do? You'll do the same investigations. You take an X-ray to see if there is any obvious hip pathology, or you need to also take an X-ray of the lumbosacral spine to see if there is any problem with the lumbosacral spine, right? And then you can do your ultrasound, your dynamic ultrasound or your ultrasound to see if there's any bursitis or tendinitis. MRI is better. And MRI is the gold standard investigation because you'll be able to see the pathology also, and also the amount of fluid, the amount of signal changes over the greater trochanter or over the gluteal tendons. And all these are better, but then an ultrasound, though it has only a 61% sensitivity, bursal distension and picking up calcifications is far better on a ultrasound than on a MRI scan, because on an MRI scan, it will just show a change in the signal. But on an ultrasound, you'll be able to see an exact calcification. All right. Management is almost trochanteric pain syndrome. So it has to be pain on the lateral aspect of the hip, and there has to be distinct tenderness around the greater trochanter on palpation. So the first is a symptom, the second is a sign, right? And there has to be one among the three that come after that. So they should either have pain on forced abduction of the hip, or you're doing a Faber test, you're doing restricted abduction external rotation, that is positive, or there should be a pseudo radiculopathy where they're talking about radiating pain down the lateral aspect of the thigh. So the first two have to be there, and one among the next three have to be there for you to call it a greater trochanteric pain syndrome. And so what investigations will you do? It's fairly the same investigations that you do. You do an X-ray to see if there's any arthritis or any structural changes. And you can also do an ultrasound to see if there's any calcifications around the greater trochanter.
Accurate lower limb diagnosis starts with the right radiological investigation. X-ray remains the first-line modality for fractures, deformities, arthritis, and joint alignment assessment. MRI provides superior visualization of ligaments, menisci, tendons, cartilage, and marrow pathology. CT scans help evaluate complex fractures and assist in detailed preoperative planning. Ultrasound and Doppler studies are valuable for vascular assessment and soft tissue evaluation. From hip to foot, precise imaging plays a critical role in every orthopedic diagnosis and treatment plan.